So sorry, just as a disclosure, I'm not yet a psychologist. I'm a trainee, so I'm in that like point of just pre-handing in my thesis. So I'm close, but no cigar yet. But it is quite nice to see the doctor, but I'm not quite there yet. So I just some thoughts about where we're going for the next half hour. I just wanted to give you a little bit of background on a study that I've just finished and that I'm submitting as part of my counseling psychology doctorate with non-speakers, and just give some information around what kind of led me to do this study. Some findings, I know I've only got half an hour, so it's just a small little nugget, and then some reflections to take home. So just some introductions. So I'm in my fifth year of counseling psychology. I've been kind of working part-time while I've been finishing the thesis portion of my training. So autism is very much my passion project. I started in the field of autism by getting it very wrong as a teacher. I worked in a small school. I didn't listen. I listened to professionals who had learned from other professionals rather than from the autistic community themselves. And so I was doing practices which, over the years I've learned are incredibly harmful. And I guess I sit here now in the position of recognizing that I actually am part of someone's trauma. And I guess part of my research is kind of a bit of retribution or a bit of reconciliation, I guess, in that. So I started then listening and actually learning from the learners that I was working with, speaking and non-speaking, and kind of built up over time, and eventually worked towards running an autism charity in South Africa. And in the charity, we focused on training and education, counseling and therapeutics support, particularly in township communities as well, where there's a lot of mythology around autism and beliefs around what it means to have an autistic child. Worked in employment and school support, and then family support, couples counselling, and then just, I guess, wider advocacy at a more governmental level, just for the rights of the autistic community. And then moved over to the UK to do my doctorate, just in the hope of, I guess, solidifying some of the work. So the background to actually doing the study is just having a look at, I was engaging a lot with the autistic community to try and find out what it is that they wanted to see researched. I'm really passionate about research, not for research's sake, but for something that has an impact. And it was very much around the feedback I was getting was around looking at how therapies can be adjusted for the autistic community. And then when I was looking at therapeutic interventions and literature for autism, these are some of the things that I did find. So in the UK, 1 in 100 people having a diagnosis of autism, or according to the CDC, 1 in 36. Of the people diagnosed with autism, 70 to 80% share a diagnosis of anxiety or depression as well. One of the things that's spoken less about is that an estimated 25 to 40% of the autistic population is non-speaking. And just as a semantics point, when I refer to non-speaking, I mean non-speaking, minimally speaking, and unreliably speaking. So individuals who know what they want to say, but when it comes out through their speech, it's not what they've intended. But even with this number of non-speaking individuals, nowhere in guidelines or in the literature I was looking at did I see non-speaking input feeding in to either the practice or the literature. And within the NICE guidelines, that obviously guide clinicians, there's no mention of non-speakers. And in fact, the only mention I found of even non-verbal was in the reference list, where they spoke about non-verbal and mental retardation, which was incredible, it horrified me. So that was a really big prompt. When I looked at kind of interventions working with autism, a lot of the methodologies I found were positive behavioral support, CBT, or when they did focus on adapted CBT, they had based this off individuals with learning disabilities as a general cohort. No one was actually looking specifically at autism or interventions kind of trialed with the autism population or non-speakers particularly. The other point I found was that kind of in looking at how non-speakers can feed in, I kind of thought about communication, and the only mentions I found of communication was a small paragraph around the fact that alternative and augmentative communication strategies are still in their infancy, and people are not, when they measure these interventions, what they're looking at is, does it lead to speech, which is not what we're looking for with augmentative communication. And so often these interventions are then left out of guidelines because they're seen as failing, because they're not reducing core autism symptoms, rather than actually focusing on the communication benefit it gives to non-speakers. The other communication strategy that is referenced in the NICE guidelines is that of facilitated communication, or supported typing, supported communication. And the reference to facilitated communication is an against reference, so recommendations not to use it. But what I found was that this was based on research done in 1996, so 27 years ago. And it hasn't kept up with communication strategies like rapid prompting methods, spelling to communicate, and all of these other communication methods that are language-based, that allow non-speakers an open way of communicating. So even before we get into a therapeutic encounter, non-speakers have no opportunity to engage, to feed in, to be a part of their care pathway, because the very thing they need to do that, the communication, is overlooked. And because it's recommended against and quite strongly in the NICE guidelines, I have found that in a lot of the institutions that, are still predominant, clients can't access them because they're being so strongly kind of veered away from through recommendations. So so with that in mind, I did the study, so bear with me, it's quite a mouthful. So my research question that I looked at was, how can the communication, sensory and social relational experiences of non-speaking autistic adults guide psychotherapeutic practice? So I really wanted to just actually create a platform for learning from their experiences. And I went into the study thinking I was going to build a model for practitioners on how we can adapt practice for this population group. Incredibly naively and incredibly arrogantly, I now recognize. So I had 12 non-speaking adult participants. I was only able to access one participant in the UK who volunteered their time. This participant actually ended up accessing through another autistic individual who kind of vetted me as trustworthy. What I found when I was engaging with the community is that people are incredibly wary of researchers, because people are afraid of research for research's sake, of tokenism, of particularly for non-speakers who communicate via letterboards or supported communication. My sense was that there's a fear of these communication methods being discredited. And so this tendency to rather steer away from research out of a fear of being harmed. And so I ended up adjusting my ethics and engaging with 2 international organizations, and from those engagements, kind of encouraging 11 US-based participants who volunteered their time. So they communicated via letterboards, which is this laminated board on the top left. Some used stencils, so it's just held by a facilitator. And others used a keyboard to type, and then their responses came onto a screen. So when I did kind of the data collection, it had 2 phases. It involved first me emailing interview questions to to the participant so that they had enough time to formulate their answers without the pressure of someone staring at them over a screen. So sometimes answers came back within about 3 weeks, 4 weeks, sometimes a little bit longer, depending on how much time they needed to regulate between answering. And then from their emailed interview questions, we did live interviews, and this was done over 2 to 3 spaces, normally about 45 minutes to an hour, just to support motor fatigue and regulation, and particularly motor regulation, but also emotional regulation during sessions. So these 2 pictures just give an idea of the communication strategies that were used by the participants. So I literally just had my Zoom screen open and would engage in conversation the way people have been engaging the lunch break now. And I've never been so bowled over by the eloquence and the self-awareness of a group of people. And even with incredible histories of trauma, what I was really struck by was the lack of anger in response to their experiences. So I wanted to kind of just share some of the themes. I know I'm going very quickly, so I can't see everyone. If someone has a question, please do feel free to shout out, or I'll check in the chat afterwards and try and respond as well. So just to say as well, at the end, I've got a small video, a little 5-minute clip I'm going to play from a non-speaker if I've got time. If I don't have time, I will stick a link in and also make all of these slides with the links available as well. So what I came up with after chatting to participants and analyzing the data was actually just a basic theory or model of working that had nothing to do with the model and everything to do with an attitude was the thing that came up. And basically what and sorry, I say non-speakers just because that's what my participants called themselves as well. So just as a point of note as well. So what the non-speakers were saying to me that and what we came up with and co-produced was that in order to provide a holistic and humanized therapy that recognizes the nuances of the non-speaking autistic profile and the complexity of what it means for them to be human, in order to do that, rather than delivering autism treatments, we need to be able to reframe our assumptions of what it means to be non-speaking and to be autistic. And once we do that, we're able to hold the tension that someone can have cognitive autonomy while still being physically dependent on another person to communicate. What a lot of the participants were sharing in terms of these assumptions and the reframing of assumptions was that they live in bodies where their brain is disconnected to their body. The brain-body disconnect was the phrase that came up in almost every participant, where their body is not responding to cues or intentions. And this balanced with research that was done by Torres and Wyatt in 2017, but also earlier research by Donnellan and co. In 2013, where Torres and Wyatt, they did a study where they looked at sensory noise that affects the integration for non-speakers. So if you can imagine sitting at your desk and reaching, say, for your cup of coffee or your bottle, your body sees that cup on your desk. It knows exactly what stimuli in your environment it has to go down. It can pick up the item. It knows how much grip it has to have, how it needs to maneuver it in the environment in order to respond and say for you to drink from it, etc. And what participants were sharing is that their body just does not read those cues. And that reflected what Torres said as well, is that there's a sensory noise, a feedback loop that happens that affects them being able to navigate their bodies. And this is where we see with a lot of individuals with a non-speaking profile, these movements that seem really quirky and these so-called stereotypical autism presentation, and often these individuals who get really unhelpful label of severely autistic, and it's because they have these bodies that don't respond. And what often happens is that as society, people have interpreted their bodies not responding to their brain is not responding, which is not the case. They are completely cognitively intact, but their bodies do not respond the same way. And so what they were sharing was that the assumptions have led to non-speaking as non-thinking as an assumption. And what that has done is it's just led to exclusion from being able to give input. The assumption that they have intellectual disability simply because they have a motor disability. The big thing that I was really struck by is so often in our training, we're taught to interpret behavior as communication. And the big thing that came out in the research was to withhold from that not all behavior is communication, because not all behavior is volitional and intentional. And so when we have a non-speaker in the room with us, is to really stick closely with what it is that they're saying. And when I say that, I mean what it is that they're spelling on the board when they are communicating with us. So it's moving more towards open-voiced curiosity. I'm noticing you're doing this, but I don't want to make an assumption. Can you please let me know what's happening for you right now? One of my participants said they didn't realize how much my apraxia was affecting me. People need to know that my mouth works independently from my brain. It's a mind-body disconnect like a stroke victim, but all of what I say cannot be trusted because I say things that are easy for my mouth. It also, this apraxia also leads to dysregulation, which is very different from behavior, because again, behavior can be seen as intentional, where dysregulation often comes from the fight, flight, freeze response. And what participants were sharing is that it creates an additional vulnerability in their emotional expression. So their bodies can react to the emotion that they're feeling, but that doesn't necessarily correspond. So someone might not cry when they're upset. They might scream when they're happy. And again, why important for us to hold back from interpreting. Often the dysregulation will come with heightened emotional sensing, and that emotional sensing linked to a hypersensitivity to the emotions of others in the space. And what participants were sharing, even with me as researcher across a Zoom screen, was their heightened sensitivity to my emotions as the person in the space with them. And within that, being able to see the authenticity of the other person. So as practitioners, when we think of like bracketing our emotions and holding back, just being aware, I guess, the potential that our clients are possibly seeing through that. So that even if we're sitting there going, okay, I'm gonna be all calm, but inside I'm going, oh God, oh God, oh God, oh God, please don't hurt me with your meltdown. That's what the individual is feeling in the space with us, not the, oh, I'm going to pretend that I'm all calm. And so what one participant shared with me was that if someone is feeling panicked, to say that, I'm feeling really anxious right now because I'm seeing that your body is doing this, not you're doing it, your body is reacting this way. So that I'm feeling a bit anxious as a result, but I know that you're not trying to hurt me right now. And I'm going to stay in this space, but I'm just letting you know that this is where I'm at. And they were saying that that is a lot more helpful because then they know it is not theirs, that we're actually owning what it is that we're feeling. The authenticity of how we're in the space with them can impact whether they connect with us or shut down. So how genuine we're being. And in its extreme, if they're feeling incredibly misunderstood, participants all shared that can lead to a meltdown. That meltdowns are often triggered by extreme misunderstanding of who they are as individuals. And the result of meltdowns can often be shame and self-punishment. So one participant said, we are unique in our combinations of sensory, motor, and communication needs. Bear in mind that we are new communicators. It's a vulnerable undertaking to discuss inner feelings. We've been silently marinating in our thoughts and feelings for so long. Revealing them to others risks a potential rejection or reaction that we're not practiced at receiving. Bottom line, it's wonderful and scary at the same time. And another participant said, I feel like sometimes it's hard for me to cry. to let my emotions out. So I just get agitated and upset when I'm just crying. So if I can be allowed to be upset, almost like allowing someone to cry, then I can come back and start to heal. Another participant in linked to meltdown said that some autistics get into trouble for melting down, though it's out of their control. I can sense fear. So I asked, what is it that you get into trouble for? Is it something that we do as practitioners? So that I thought we can figure out what it is that we need to change. And his response was, I can sense fear and I don't mean to scare. So that feels like unintentional punishment. I hate causing fear, but I understand it because I scare myself. And I just, again, why it's so important for us to be so reflexive when we're working with these individuals. They're honestly the most incredible human beings. So for practitioners, it means that we need to be aware of unintentional self-disclosure, that a lot of non-speakers can see behind the facade of therapist, and they're seeing us as human beings. So the irony is that we're being asked not to interpret their behavior, but they're interpreting ours from the word go, and they're interpreting us from the word go as well. They know whether we presume competence or not. They know whether we think of them as incompetent or intellectually impaired. And they know whether we think of them as capable human beings. Authenticity for us is key. So are we being genuine with them? And then, like I said, if we can't bracket our emotions properly, if we can't take a breath and be calm, either to step away or to open what we're feeling and to bring that into the therapeutic process, presuming competence in that the individual we're sitting with can hold that space with us. We often panic when we see dysregulation because it can be quite scary, because it's not only out of our control, but often when someone is in extreme dysregulation, it's out of their control as well. And that can be a scary space to sit in. But if we can presume competence and that individual wants to process that with us, that can be the key to working through it. So it does require much deeper reflexivity and personal work and supervision for us as practitioners working with this group. It's not about us, I guess, writing our notes and moving on. It's a lot of reflection. The big thing that came out is communication as a humanizing agent. So communication is that which includes unlimited expression and language. So often when we think of communication for autism, and the thing that's often mentioned in the guidelines are choice boards and PECs, picture exchange communication. But what we forget is that these come with a power imbalance because we are always choosing the pictures for the boards for the individual. So it's always going to be limited for them and limited to what we have chosen for them. The other thing is that communication with individuals who have apraxia is most likely supported. So a lot of people try to work towards independent communication, but that can be really disabling for individuals who struggle with motor support and motor regulation in their body. So being comfortable with communication that is supported, and not necessarily hand over hand supported, but supported in someone being in the space and regulating with them. So again, presuming competence lying at the foundation. So one of my participants said, my life was miserable. I wasn't able to advocate for myself. I was angry and I acted out a lot, or I just went along with the program. Now I'm able to demonstrate understanding and competence, and I can express my wants and needs. People acknowledge my presence and my humanity. The thing with supported communication is that it means we have multiple voices in the space, and I know this is the perfect forum for this because we're amongst systemic practitioners, but it's that holding in the space that it's not therapist and client, it's therapist client, so CRP, communication regulation partner, and often that the CRP is a parent, because communication regulation partners are a bit far and few between. So there are these multiple voices in this space. The individual is going to type their response and the partner is going to voice it, but holding in mind that their relationship is going to impact how fluent that person is on the board when they are pointing to their letters. It's going to communicate what they are comfortable disclosing. because sometimes parents can be a part of the trauma, or sometimes the individual might want to protect their parent from the trauma. And that can create a power imbalance. The other thing that I often witnessed was when topics became really difficult. So if a participant, for example, was disclosing trauma, I would notice parents putting down the board and swapping with another person and doing this kind of musical chair dance that completely disrupted the flow of conversation. And what it did is it stopped that individual talking about their trauma.
So 4 minutes left, Keri.
All right, thank you. I'm going to speed myself up. So just being aware of the power imbalance, that you still have someone holding a board in that scenario. But with that, recognizing that parents have come into the room, and with children who are non-speaking, this parent has often spent their life being the voice for that person. They have unlearning as well when their child or adult child is now using their own voice. And so they're learning to not be the storyteller anymore. So key points for us, just boundary clarification between therapist, communication partner and the client, and within sessions giving primacy to the non-speaker's voice. So what they have to say, if they're spelling, that comes first. Verbal is so much quicker and louder and easier. So it is important to hold in mind slowing that down and sitting with silence and waiting for the non-speaker so that their voice comes up first. And then just, so some grounding principles, I guess. It's all about relationship. It's not about model or technique. Just remembering that the brain-body disconnect doesn't reflect intellect or cognitive functioning. What you see is not what you get. So constantly checking in with them via the spelled communication. Presuming competence as a foundation principle, and then attitude over modality and technique, curiosity over knowing, and that communication trusting the credibility of the non-speaker's communication gives them relationship safety. And then underlying that, our own authenticity and calm and reflexivity and self-attunement helps them feel safety in the room as well. I know I've sprinted through that. I do have a little video from Noah, who's a self-advocate, but if you'd like, I'd be happy to stick a link in. It's definitely worth watching. It's a presentation he's made himself about his experience. So yeah, would love, even if not now, for people to take a moment and check that out.